there's been growing attention paid to alcohol misuse worldwide. As the Dean mentioned, the World Health Organization has developed a strategic plan to reduce global harm from alcohol misuse. Alcohol misuse is the 5th leading cause of death and the 3rd leading cause of disability worldwide. Over 3.5 million deaths each year worldwide are attributed to alcohol misuse. Here in the United States, alcohol misuse is the 3rd leading cause of death, following tobacco use and sedentary lifestyle and obesity. It accounts for nearly 90,000 deaths each year. The leading type of alcohol attributable death is injuries. Injuries are the leading cause of death in the United States for people ages 1 through 44, and alcohol misuse is the leading contributor. So it's the leading contributor to the leading cause of death among young people in the United States. If we look at the types of injury deaths, before I get into that, I should talk about the costs. CDC did a recent estimate of $224 billion annually being lost in this nation as a result of alcohol misuse. And over half of the costs are paid for by people other than the drinkers. It affects 42% are paid by federal, state, and local government. 3/4 of the costs result from binge drinking. By binge drinking, 5 or more drinks in a 2-hour period for someone my size, 4 or more drinks in a 2-hour period for a woman. If I had that much to drink during a 2-hour period, I'd reach a blood alcohol level of 0.08, which would make me legally intoxicated in every state in the United States. So it's a major problem. The leading problem is traffic crash, motor vehicle injuries, and these deaths don't just involve the drinkers. If there's a drinking driver under 25, half the people who die in crashes involving those drinking drivers are people other than the drinking driver. So just as when we turned the corner on tobacco, when people began to realize that smokers weren't just harming themselves, they were harming other people, the same is true with regards to alcohol, and particularly alcohol injuries and particularly traffic crashes. We've been making some progress in reducing the motor vehicle deaths, and in 1988, for the first year ever, overdose deaths exceeded the number of traffic deaths in the United States. In fact, I read in the paper this morning, the Public Health Department here in Massachusetts has just released a report indicating great concern over the number of opiate deaths and the increase in opiate deaths. There's been a shift nationwide from overdoses from illicit drugs in inner cities to prescription drug misuse, primarily painkillers and sedatives in rural and suburban areas. And I understand that Western Massachusetts in particular has been very much affected by this. It turns out that alcohol is involved in a lot of those overdose deaths and hospitalizations. We published a paper just a couple of years ago in the Journal of Studies on Alcohol and Drugs. We looked at the national inpatient sample, which is a probability sample of community hospitals across the country. And the data from that data set revealed that there are 1.6 million hospitalizations every year as a result of overdoses. And half of those hospitalizations involve alcohol. If you think about it, if people have co-occurring problems, drug problems and alcohol problems, their judgment is often affected, and they're likely to take higher and potentially more lethal doses of both alcohol and drugs. And alcohol can pharmacologically potentiate the effects, particularly of the sedatives and the painkillers. And we know that people can overdose with lower blood alcohol level, lower blood alcohol content, if they have other drugs on board. One of the interesting things, when we looked at, we focused in on 18 to 24-year-olds, sort of the college age population. And what we found was that over the preceding 10 years, there had been a 25% increase in overdoses involving alcohol only, a 56% increase in overdoses involving drugs only, but a 76% increase in the combination of alcohol and other drugs. So I think that alcohol's role in the overdose problem is underestimated. CDC estimates about a half of the opiate overdoses, excuse me, about 20% involve alcohol. I think that's an underestimate. The ICD-10 codes require that if there's a drug, when there's an overdose, that the drug be recorded. So oftentimes, even if the alcohol test has been done and the person's found to be alcohol positive, it doesn't get reported, the drugs get reported. So it's a looming problem. On the other hand, in the traffic area, we've made great progress. Alcohol-related traffic deaths in the United States since the early 1980s have literally been cut in half on a per population basis. That's the white line here. Whereas traffic deaths that don't involve alcohol have only come down about 11%. We look here in Massachusetts, a very similar sort of picture. Alcohol-related traffic deaths have declined 60% from 407 in 1982 to 162 in 2012. The non-alcohol related deaths are also down somewhat, but not nearly as much as the alcohol related deaths. Part of the reason that we've made progress in reducing the alcohol-related deaths is that most fatally injured drivers are tested for alcohol. And we have data from the National Highway Traffic Safety Administration that's recorded by state, by year, and by community by year. So it's provided a ruler or benchmark that scientists can use to study what kinds of legal and community interventions are effective in bringing down the problem. Unfortunately, for other types of alcohol-related injuries, homicides, suicides, falls, drownings, burns, poisonings, and so on, we don't have as consistent testing. CDC does have a national violent death registry where there are 17 states that test 70 to 80% or more of homicides and suicides. In that area, we're sort of like where we were in the traffic area back when I first started working in this, where we had the so-called good reporting states. But now most states are good reporting states, and the reporting is sufficiently high that the National Highway Traffic Safety Administration has been able to develop an imputation scheme where they can identify, even when there's not a test result, what are the characteristics of crashes that involve alcohol, and they can impute. And they've tested this out by going to states that have comprehensive testing for both fatally injured drivers and surviving drivers in fatal crashes. And they use their imputation scheme, and then they go match it up with the actual test results and find out that they, on an annual basis, can get within a percentage point or two of what the actual number is. We don't have that type of imputation scheme for the other alcohol-related injuries. What we've learned over the years, there have been over 100, we've learned that we have brought down the total of alcohol-related traffic deaths by over 300,000. That was an estimate back in 2006, so it's probably more by now, which is more than the combined impact of increases in safety belt use, airbags, motorcycle helmets, and bicycle helmets combined. So it's really an American success story that we've been able to achieve those kinds of reductions. We know that impairment on tasks that are necessary to safely operate a motor vehicle, that impairment really begins with the first drink. And by the time one gets to a blood alcohol level of 0.008, virtually every driver is impaired on some task that's needed to safely operate a motor vehicle. We also know that each drink increases the fatal crash risk more for younger drivers than it does for older drivers. Younger drivers have less driving experience, and we are learning comparisons of chronic heavy adolescents with those adolescents who are not chronic heavy drinking. We even now have prospective studies that indicate that there are deficits, cognitive deficits in memory, in spatial relations, and executive function and planning. All of these, by the way, are important to operating a motor vehicle. And we've learned that even after a month of supervised abstinence, young people who experience alcohol dependence still have these decrements in memory and spatial relations and executive functioning. And as I said, each drink increases the crash risk more for the younger drinkers than it does for, so let's say at a blood alcohol level of 0.08 to 0.099, for drivers ages 16 to 20, there's a 32-fold increased fatal crash risk per mile driven, compared to about a 20% increase for drivers age 35 or older.